Good afternoon. Today we will look into the neuroimaging in the neurocutaneous syndrome. So neurocutaneous syndrome, also known as phacomatosis. So these are the heterogeneous group of the disease with inheritance patterns and the degree penetrance variable. Corresponding to some cases, it is new spontaneous mutation, while in the other cases, it may be the congenital malformation, and the importance of performing the imaging and the genetic tests. There are many more. We can see there are some why the neuroimaging is important in neurocutaneous syndrome. Why we radiologists are concerned with such kind of skin disease? Why? So it is first of the thing. It is diagnostic importance. Why? Like in some cases, it is a pathognomonic. Like if you can see bilateral vestibular schwannoma, it is 100% pathognomic for NF2. Like in other case, you can see portoine stain in the newborn or in the child. You can think there is some underlying pathology in the brain. Okay. In other case, it can confirm your clinical suspicions, and also to screen the family. Like certain cases are there, certain diseases are there, they are run in the families. And yeah, in the regular monitoring, like in NF1, there are in early disease in the childhood, there is only a very few foci of altered signals in the white matter, but later on it can be turned out to be a cytoma. So this is the clinical and radiological importance of neuroimaging in the case of neurocutaneous syndromes. So by definition, it is phacomatosis neurocutaneous, including the skin and as well as the nervous system. But however, there are some exceptions like Sturge-Weber. There is no neoplastic component within. In VHL, you cannot find any cutaneous manifestations. So there are some common and some uncommon phacomatosis. Most commonly encountered are NF1, NF2, tuberous sclerosis, Sturge-Weber syndrome, VHL, whereas uncommon varieties are diaphragmatic Cowden, basal cell never syndrome, Proteus, Hippel-Lindau, ataxia telangiectasia, meningiomatosis. So we will start with neurofibromatosis. This is the most common, most frequently encountered clinically. So NF is autosomal dominant. NF1 and NF2, two varieties. NF1 is due to mutation in the NF1 gene on chromosome 17, whereas NF2 is mutation in NF2 gene on chromosome 22. So NF1 presents in the childhood very early, whereas NF2 frequently in the later age group, mostly 30-40. So NF1, also known as von Willebrand's disease, in certain cases, NF1 is highly disfiguring, like two large Plexiform neurofibromas in the skin, so also known as elephantiasis neuromatosa or elephant man disease. So we'll start with NF1. So what is the cutaneous neurofibromatosis? You can see certain spots, macules, papules in NF1 patients. So which are they? So Café spots, list nodule, Plexiform neurofibromas, axillary frecklings, and molluscum fibrosum. So this is how Café spots can be visualized on the skin. This is the list nodule. Actually, it is a hemangioblastomas, not a true tumor, just tumor-like thing. It is seen in the iris, melanocytic hemangioblastomas of the iris. This is the Plexiform neurofibroma. You can see a large disfiguring areas in the skin. In the first image, you can see yes, Sphenoid dysplasia with large neurofibroma. In third, in the chest wall, you can see a large Plexiform neurofibroma. This is axillary freckling, molluscum. So what is the imaging aspect in the neuroimaging aspect in NF1? We can start from the scalp and going inward. So skull meninges in the orbits involved. Cutaneous scalp. Multiple small cutaneous neurofibromas can be seen in the scalp. They are solitary or multifocal. Many times it can infiltrate into the cavernous sinus and all. Sphenoid dysplasia. So actually there is hypoplasia with resultant enlargement of orbital fissure, enlarged middle cranial fossa, temporal lobe may be protrude into the orbit. Another thing is dural ectasia. Here you can see this is the plain T1 weighted images of the brain. Here in the image you can find out very small hypo-intense lesions, nodules in the scalp. On the post-contrast study you can see that nodules show intense enhancement. It is not only one, there are multiple smaller nodules. It's classical neurofibromatosis, cutaneous neurofibromatosis. So this is a rope-like large plexiform neurofibroma. You can see multiple in every nerve root, along the every nerve root, significant rope-like thickening of the exiting nerve roots. So this is the classical example of the plexiform neurofibroma. The third image is you can see a sphenoid wing dysplasia. You can see there is an absent sphenoid wing. That's why the orbit is displaced, as well as the medial temporal lobe is protruding inside the orbit. So this is classical sphenoid wing dysplasia with multiple cutaneous neurofibroma. So neurofibromas, they may be localized, plexiform, or diffuse. Localized may be fusiform variety. Plexiform may be rope-like, like which I have seen on that image, or bag of worm-like. Diffuse, like plaque, which we have seen on the skin surface. So this is the sphenoid wing dysplasia. Here in the right side, you can see the normal orbital fissure. On the left side, due to absent sphenoid wing, you can see the enlarged orbital fissure. This is classic case of sphenoid wing dysplasia. So what we found in the brain? So hyperintense T2 and flare-weighted white matter foci. So this is the basic of what we can do in such cases. Like it is commonly seen in pediatric person. A person may came with normal screening of brain or something, and we found some hyperintense foci in brain in pediatric age group. We certainly mark it as UBO and some follow-up. But once you found it, please go and see if patient has any other signs and symptoms like any visual skin patches or something related to NF1. So this may be the very FOCI, early foci of signal intensity in the brain, which is classical of NF1. Usually it is back in the first case and usually wane. But yeah, we need to follow this case because that may turn out to be astrocytomas in the later age group. So another one is astrocytomas. So most common variety of astrocytomas are pilocytic astrocytomas. Commonly they are found in the optic pathway, hypothalamus and brainstem. Malignant astrocytomas, anaplastic glioblastoma multiforme are very less common in NF1. It is also involve the arteries. How? Actually, they causes progressive severe narrowing of intracranial vessels, specifically ICA, stenosis, that leads to Moya type of phenomenon, which is commonly found on the arteriography. And another like vessel disease, maybe fusiform ataxia, AVM, you can found. So here on T2 weighted images, you can see a very small foci of signal intensity. So this is classical FASIS, known as FASIS in the NF1. Most commonly they are found in children. This need to be followed up. It's optic nerve glioma as well as pontine glioma you can see in NF1 figures. Here you can see a very MC and ICA, it is very thinned out, and there's a very significant atrophy also. This is, and on the imaging arteriography you can see this kind of Moya type of pattern due to severe stenosis in the ICA at this point. So this is the basic brain imaging in NF1. So what are the other abnormalities that you should look for when you found this is a case of NF1? Don't let it go, or at least inform the clinician. Okay, yeah, this is suspected case of NF1. You should go and screen the other areas like thorax, abdomen, to look for the mediastinal masses, lung parenchymal disease, neurofibromas, other in anywhere else, lateral thoracic meningocele, extradenal chromocytomas are more common in such age group. Another thing is skeleton neurofibromatosis. In skull, we have already seen this sphenoid dysplasia as well as the enlarged neural foramina. Why because of that plexiform or a localized fusiform variety of the neurofibroma exiting nerve roots that causes the enlarged neural foramina. Another variety is lambdoid suture defects. In the spine, you can see a posterior vertebral scalloping due to that pressure effect, chronic pressure effect due to neurofibromas, scoliotic deformities. In rib, similarly, due to pressure erosion, everything, rib notching, ribbon ribs are seen in long bone pseudoarthrosis. So these are the diagnostic criteria of the NF1. At least two of them are required to label it as NF1. One is cutaneous lesions, eye abnormalities, distinctive bone lesion, and family history. Like what I already narrated about the cutaneous lesions. Spots, frecklings, neurofibroma, plexiform. A plexiform neurofibroma is too specific for NF1. It is is not in any other varieties. Eye abnormality, leaf nodules, optic nerve glioma, or any brain, optic pathway glioma, bone lesions, and family history. Now we'll look for the NF2. NF2 is also known as neurofibromatosis with bilateral vestibular or acoustic schwannomas. These pathognomony. Historically, they are central neurofibromatosis, whereas the NF1 is peripheral. More manifestation in peripheral, less in central, whereas in NF2, more common central nervous involvement. Pathology, most common NF2-related schwannomas are vestibular schwannomas. Meningiomas occur in approximately half of the patients with NF2 and can be found anywhere in the skull and the spine. Most frequent sites are along the falx and the cerebral convexities. Another syndrome, also known as MIS-ME, multiple inherited schwannomas, meningiomas, and Ependymomas. Diagnostic clinical features of NF2. Bilateral vestibular schwannomas, most classical. First degree relative with NF2 and unilateral vestibular schwannomas if younger than the 38. Or the first degree relative with NF2 and two of the following, like multiple meningiomas, glioma, schwannomas, or juvenile posterior subcutaneous lenticular opacity or the cataract. Probable NF2 unilateral vestibular schwannoma younger than 30 with following like meningioma, glioma, schwannoma, and same thing. If greater than 2 meningiomas in one of the following: one vestibular nerve schwannoma younger than 30, one meningioma, glioma, schwannoma, or lens opacity. So here we can see classical ice cream cone appearance tumor in the right CP angle. It has tail going inside the interior acoustic canal and protruding inside the brain and causing indentation over the CP angle. On the left side, you can see a very small tumors or neurofibromas, schwannomas here. So these are the varieties of schwannoma, bilateral acoustic schwannoma, as well as we are seeing a meningioma, highly vascular along the sphenoid wing. This is the bilateral vestibular schwannoma, highly intensely enhancing. If small, you can see just a significant enhancement. If it enlarges much more, you can see a necrotic component calcification within the schwannoma. Multiple meningioma. You can see here multiple extraaxial enhancing lesions along the falx, along the convexities. This is multiple meningiomas. Similarly, multiple spinal schwannomas, multiple extraaxial or intradural enhancing lesions in the spine. Sometimes you can found the Ependymomas as well as the neurofibromas. So what is the difference between NF1 and NF2? NF1 is more common. 90% of the NF is NF1, as only 10% is NF2. Chromosome, you almost always diagnosed by the age of 10. This is important because NF1 usually present in the early age group, whereas NF2 usually diagnosed in second to fourth decades. So cutaneous manifestations are more common in NF1, like spots, leaf nodules, cutaneous neurofibromas, plexiform neurofibroma. It is pathognomonic for the NF1. whereas NF2 cutaneous eye involvement is not that much. Very rarely you can find the juvenile subcapsular obesities as this imaging part is concerned. In NF1, CNS lesions are less common as well as compared to NF2, whereas CNS manifestations are always there in 100% cases. In NF1, you can find T2 or flare hyperintensities that I told you, foci of T2 and flare hyperintense foci of white matter. They are actually myelin vacuolization. Histologically, they have shown that very early myelin sheath was abnormal, and that will give rise to such kind of abnormal foci, and then that may in future may give rise to astrocytomas. Another CNS lesion in NF1 is astrocytomas like optic gliomas, optic pathway gliomas, and other like pontine gliomas. Other lesions like sphenoid wing dysplasia, dural dysplasia, Moya phenomenon, and a neurofibroma spinal nodules. As in NF2, you can see CNS involvement, CNS lesion in 100% cases, like bilateral vestibular schwannomas, almost all cases. If it is bilateral vestibular schwannoma, you can 100% surely you can say it is NF2 only. In other non-vestibular schwannomas, meningiomas, and cord ependymomas, often multiple. The schwannoma of the Neuro. So now we will move to tuberous sclerosis. The name composed of Latin tuber, that means a swelling, and the Greek hard, refer to the pathological finding of thick, firm, and pale gyri called the tubers in the brain of the postmortem patient. These tubers were first described in 1918 by the Bonville. The cortical manifestation may sometimes still be known as Bonville's disease. The tuberous sclerosis complex is a neurocutaneous syndrome characterized by formation of the non-malignant hematomas and the neoplastic lesions in the brain, heart, skin, kidney, lung, and other organs. So, tuberous sclerosis, 50% of the cases, histology is the autosomal dominant inheritance, and 50% it is sporadic gene. So, what is tuberous sclerosis complex? It is triad of seizure, adenoma sebaceum, and mental retardation. You can see multiple adenoma sebaceum here, fits, and the mental retardation. This is known as classical triad of tuberous sclerosis complex. What is the cutaneous manifestation in the tuberous sclerosis? One is adenoma sebaceum that we have already seen, Axillary spots, Shagreen patch, Confetti lesions, and periangular fibroma. So this is adenoma sebaceum, facial angiofibromas. This is Axillary spots, hypopigmented spots. This is Shagreen patch. This is how they look. Confetti lesions, and this is classic of periangular fibroma. Moving to neurological tuberous sclerosis, what we can find in the CNS, it is cortical and subcortical tubers, white matter lesions, subependymal nodules, and subependymal giant cell astrocytoma. Cortical tubers are the firm, whitish, pyramidal shaped elevated area of the smooth gyral thickening with or without central depression that grossly resemble the potatoes. Here you can see this is the normal area, where here you can see the very white hard areas. Similarly here you can see abnormal areas of cortical thickening. So this is tuber. What is this subependymal nodule? Subependymal nodules, SENs, are located immediately beneath the ependymal lining of the lateral ventricles along the course of the caudate nucleus. Subependymal nodules appears as elevated, rounded, hematomous lesions that grossly resemble the candle guttering or dripping, are often calcify with increasing the age. In the younger age group, we will not find SEN as a calcified lesion density, but in the later age group, they are definitely going to calcify. White matter lesions are almost universal in patients with tuberous sclerosis. They appear as a foci of bizarre dysmorphic neurons and balloon cells in the subcortical white matter. or in the fine radial lines extending toward from the lateral ventricle. So this is the actually white matter lesion. As per as the neuronal developmental theory, the cells migrate from the central zone to peripheral zones. So this is the zone of migrations. So that in TS you can find multiple linear or radiating patch of white matter lesions extending from central to peripheral zones. So this is the along the line of neuronal migration, classic of white matter, and they are pathognomonic for the TS. And subependymal giant cell astrocytomas are also known as subependymal giant cell tumor. Is almost exclusively in the TS. Grossly appear as a well circumcised solid interventricular masses located near the foramen of Mendo. This is all manifestation of tuberous sclerosis complex. Here you can see cortical thickening, Walter signals, white matter, subcortical white matter. This is radial band extending from central to peripheral white matters. Here we can see some nodule within the lateral aspect, within the right lateral ventricle, subependymal nodules. In infants, the tuber appears thickened hyperintense cortex. This is related to myelin, and later on it will change the intensity and hyperintense on T2, hypo and T1 in the later age group. In older, yes, similar. White matter lesions. This is the CT findings. Here you can see hypo areas here. This is the white matter lesion. A smaller calcified subependymal nodules. This is a large white matter abnormalities. Chunky calcification within the subependymal nodules. Subependymal giant cell astrocytomas. So basically, in some of the cases, the subependymal nodule may turn into the subependymal giant cell astrocytomas. Usually, they are the subependymal nodules are small, usually non-enhancing. But if you can find a large enhancing nodules in such cases, in follow-up cases which was not previously enhancing, you can turn is a subependymal giant cell astrocytomas. Diagnostic criteria: definitely two major feature, one major plus two minor, probable. Okay, major. What are the criteria? Three hypomelanotic patch, facial angiofibromas, Shagreen patch, periangular fibromas, multiple retinal hematomas. On imaging, subependymal nodules, cortical tubers, cardiac rhabdomyomas, renal angiomyolipomas, subependymal giant cell astrocytomas, and lymphangiomyomatosis. Okay, in imaging you can found the white matter hematomas, radial migration lines, hematomas, rectal polyp, non-renal hematomas, bone cyst, and renal cyst. So, differential diagnosis of tuberous sclerosis. Sometime it can you can see a similar pattern. Then how to differentiate? Like you can see subependymal type nodules in other cases. So how to differentiate? Whether it is subependymal heterotropia, or it is Sturge, or it is subependymal nodule of tuberous sclerosis. So it is non-calcified. It is subependymal heterotropia, differential diagnosis in the non-calcified tuberous sclerosis subependymal nodule. If it is calcified, we have to differentiate it from the Sturge. DD of the cortical tuber like FCD, focal cortical dysplasia, and a subependymal giant cell astrocytoma. So we differentiate from the other masses in the foramen magnum. So how to differentiate subependymal nodules from the subependymal heterotropia? So subependymal nodules are round to oval with their long axis will be perpendicular to the ventricular wall. Here you can see the subependymal nodules. The long axis is perpendicular to the ependymal wall, whereas in the subependymal heterotropia, you can see the nodules are not perpendicular. Actually, it is parallel to the ventricular wall. Long axis parallel to the ventricular wall. So usually subependymal heterotropia is always isointense with the gray matter on all the pulse sequences. No any difference in the that intensity. Whereas in the subependymal nodule, it is always variable. This may be calcified, but whereas the subependymal heterotropias will never ever calcify. Uh, Subependymal nodules may be enhanced, but will not enhance uh, subependymal heterotropias. So this is the another CMV infection torch. You can see calcified uh, lesions or calcified area along the ventricular wall. So here you have to differentiate between the tuberous sclerosis. How? Because we know subependymal nodules are there in tuberous sclerosis, but they will take time to calcify in later age group, whereas this is pediatric age group, torch infection is common. So what we have to look in the tuberous sclerosis, if patient came with us with tuberous sclerosis lesion in the brain, we should advise him for the abdominal ultrasound and other chest X-ray or the chest CT and abdomen to look for the other areas like renal, what we can found the commonly angioma lipomas, hyper echoic on the ultrasound, in variable fat density lesion on CT with enhancement, multiple cysts. Some of them may be turned into the RCC or oncocytoma. Retroperitoneal LAM and GIT polyps. This is the abdominal lesions in the tuberous sclerosis. Thoracic lesions are lymphangiomyomatosis and cardiac rhabdomyomas. Skeleton, sclerotic bone lesions, hyperostosis of the inner table of the calvarium, scoliosis, and the bone cyst. So this is the AML, fat density variable enhancement, cardiac, multiple cardiac rhabdomyomas. Uh, Now we'll see the Sturge-Weber syndrome, also known as encephalotrigeminal angiomatosis. It is hallmark or variable combination of the capillary malformation of the skin in the distribution of the trigeminal nerve, and retinal choroidal angiomas, and third is cerebral capillary nervous leptomeningeal angiomas. Sturge-Weber is an embryonal developmental anomaly resulting from the errors in the mesodermal and ectodermal development. When the development is take place, the mesoderm and ectoderms are being separate in the later, but unlike the other neurocutaneous syndrome, occurs sporadically. Etiology: at 4 or 5 weeks of the gestation, the visual cortex is juxtaposed to the optic vesicles and the upper part of the embryonal phase. During this period, a primordial venous plexus surrounding the neural tube and invade into the adjacent fetal brain, skin, and the eye. The somatic mutation at that time result in the persistence of the primitive veins and lack in the definitive cortical veins. So this is the pathology, and once you understand the pathological finding, you can definitely know what are the radiological findings. So pathology is pile, leptomeningeal angiomas, cortical venous they are the actually abnormal primitive venous plexus which is does not maturate at time and then will give rise to a significant severe cortical ischemia, and that will lead to significant atrophy as well as calcification of the unilateral brain. So this is the basic pathology. Cortical venous ischemia, atrophy, parieto-occipital regions are more involved than the frontal. Clinical findings: unilateral facial nervous flammers, port Weinstein, cutaneous distribution of V1, V2, and V3 nerves. This is the port Weinstein, unilateral. Here you can see pile angiomatosis. These are the abnormal pile vessels which are not maturate. You can see normal on the other side and abnormal on the side. So here, this causes a severe ischemia of the brain, cortical atrophy, and some shrinkage of unilateral hemisphere. Imaging: CT, atrophic cortex, cortical calcifications uh, that will increase with age. Thick ipsilateral calvarial sinuses are enlarged. In MR, you can see cortical, subcortical hypointensity on T2, blooming on the gradient images. Pile angiomas will definitely enhance intensely on the post-contrast studies. Ipsilateral choroid plexus enlargement. So plain CT, you can see a normal hemisphere on right side. On left side, you can see significantly atrophy with gyral cortical calcification, pathognomonic for Sturge-Weber. The, similarly, in the MR, you can see abnormal pial vessel with blooming on the cortex. On the post-contrast, you can see intense enhancement, coral plexus lesion, intense pial enhancement ipsilaterally. Gradient image, you can see the primitive vein complex. Okay, next is VHL, von Hippel Lindau disease, is known as VHL syndrome and familial cerebroretinal angiomatosis. Genetics, autosomal dominant, 80%. VHL type 1 and type 2. Okay, CNS manifestation of VHL. Hemangioblastomas, it could be cerebellar, spinal, posterior fossa most commonly, cerebellar, spinal or retinal. Choroid plexus papilloma and endolymphatic sac tumor. So this is the how hemangioblastoma look like. A large cystic lesion with enhancing nodule which is adjacent to pile or the ependymal lining with enlarged draining veins. This is cerebellar, this is spinal. You can see a large cyst with enhancing nodule adjacent to pile with large draining vein. Multiple hemangioblastomas, retinal angiomas or junior bilateral endolymphatic sac tumor. So infratentorial hemangioblastoma, you can see a large cyst with a nodule. The nodule shows significant intense enhancement, which is like adjacent to meninges, enlarged draining vein. So how to differentiate hemangioblastoma versus pilocytic? In the young adult, hemangioblastoma versus pilocytic astrocytomas. Hemangioblastoma, young adult, tumor nodule shows vascular phloids, whereas in the pilocytic lacks the vascular phloids. The hemangioblastoma nodule abers the pile or ependymal surface, whereas the pilocytic astrocytoma, which is look like a cyst with nodules, the tumor does not often abers the pile or the ependymal surfaces. So this is the another thing is endolymphatic sac tumor. Endolymphatic sac tumor, significant destruction, enhancement, significant enhancement on the MR, significant vascularity. So VHL, what the other findings in the abdomen? What when you see a patient with cyst with nodule enhancement in the brain, don't ask clinician to look for the other areas also, like abdomen. You can see pancreatic, renal, adrenal, liver and epidermal pathologies. Like in pancreas, you can see multiple cysts. You can also find the microcystic adenomas, LSZ tumors and adenocarcinomas. In renal, you can see cyst, AML and RCCs. In adrenal, pheochromocytoma, multiple liver cysts and epidermal cyst as well as papillary cyst adenoma. So this is VHL manifestation, endolymphatic sac tumor, retinal angiomatoma, cerebellar hemangioblastoma, spinal hemangioblastoma, pulmonary hemangiomas, liver hemangiomas, pheochromocytomas, RCC, renal cyst, pancreatic cyst, epidermal pathologies. So 45% of this with VHL develops hemangioblastomas. 20% of those with hemangioblastomas have VHL. So this is clinically significant. So if you found VHL, hemangioblastoma in brain, almost 20% of the brain also have the VHL mutation, so you can found the other pathology outside. So always screen patient for the abdomen, chest and whole body also. Less common varieties like Fermani is known as the sarcoma family syndrome of Fly and Fermani is autosomal dominant familial tumor syndrome characterized by the spectrum of malignant neoplasm, which are the CNS tumors, astrocytoma, gliosarcoma, choroid plexus tumor, medulloblastoma, pinnate, very rare variety of ependymoma, oligodendroglioma, and meningiomas. less enhanced in Cowden syndrome, also known as multiple hematomas neoplastic syndrome. The classic brain hematomas is dysplastic gangliocytoma of cerebellum, also known as Lermite-Douglas disease. Uh, this is the classic example of Lermite-Douglas. Many I have seen a few of the cases where such kind of lesion is either reported as acute infarct, sometimes you can say as a restricted diffusion, but on the sequential imaging or in follow-up you can follow the similar pattern. So this is the hematomas tissue, Lermite-Douglas disease. So diagnostic criteria, pathognomonic are Lermite-Douglas, dysplastic cerebellar gangliocytomas, characteristic Neurocutaneous lesions, papillomatous lesions, facial, acral keratosis, major criteria, breast cancer, thyroid cancer, and endometrial cancer, macrocephaly, minor are MR, GI polyps, fibrocystic breast disease, lipomas, fibromas, GU tumors, genitourinary structure malformation, uterine fibroid. So what is the take-home message? So what I really want to convey you that when you found a lesion in the brain, like multiple meningiomas in the young patients, so we are we have to look for them. Either they are inherited as a like NF2 or the other abnormality. Similarly, if you found screening there is multiple nodules or cutaneous neurofibroma, go for the neuroimaging to look for the any CNS abnormalities. And the other thing, if you found very in NF1 patient a foci of signal abnormality in white matters, kindly follow it up. It may it waxes or vanishes in the later age, but it may turn out to be astrocytomas, or you can find the optic gliomas which are asymptomatic at that stage when you can take it out, or it in other time it will turn out to be inoperable. So similarly, if you found this cystic lesion with a nodule in cerebellum, like in VHL, 20% chances are there is multiple abdominal as well as chest and other abnormalities. So this is the take-home message from the neurocutaneous syndrome. Vice versa, if you see the patient with skin lesions, go and screen the CNS, and in CNS you found something related to this, go and screen the other areas to find the abnormalities and to have the